Bismillahirrahmanirrahim. Assalamu alaikum and good morning. Before sharing the cases, I would like to convey my thanks to the organizing committee for inviting us at this exciting event. As my senior colleague and mentor, Dr. Mehdi Raza has already elaborated the basics and applications of myocardial perfusion scan, I would go to the cases and will just quickly and briefly share few of the clinical cases. This is a 65 years of age hypertensive lady who presented to us with dyspnea NYHA class 2. She had a previous history of PCI to LAD and RCA 5 years back. Among other risk factors, she had family history of ISD. 2D echo showed good LV systolic function and LVEF of 60%. So gated SPECT MPI with pharmacological stress and post GTN viability protocol was advised. On dual phase stress myocardial perfusion scan, here we see it is a polar map. On the polar map, we see a homogeneous radiotracer distribution in all three territories. On the polar map, we have apex, anterior, septal, and lateral and inferior walls. So there was fair tracer uptake and reuptake on rest perfusion scan, and the EF was established as 65%. On 3D slices, we have elaboration on the short axis slices, vertical long axis, and horizontal long axis. So the scan was normal. And second case, 68 years of age, hypertensive gentleman, smoker with history of NSTEMI 1 month back, presented to us with complaints of backache. 2D echo was normal. Coronary angio showed LAD with moderate disease in the proximal course and critical disease at the ostium of diagonal. Gated SPECT MPI with pharmacological stress with post-GTN viability protocol was advised. On MPI scan, on stress images, we see a moderate to severely reduced radiotracer uptake in the anterior wall, which shows fair tracer reuptake on rest images. The SSS score was 19, SRS 9, and the total ischemic burden of this case was 11%. So we recommended an revascularization for this patient. On reversibility map, there was excellent reversibility involving the anterior and adjoining part of anterolateral region. On the severity map, there was SDs up till 8, and which were normalized on the rest scan. And on the slices images, we saw reduced tracer uptake involving the anterior wall on all three slices.
Can you use the pointer, please?
Okay. If you use the mouse. Okay, its mouse is not working, I think. I was actually using the mouse. So on slice images, we see moderate to severely reduced radiotracer uptake involving the anterior wall on the short axis, and then vertical long axis, and then horizontal long axis. Coming over to the next case, 31 years of age gentleman with history of anterior wall MI 2 months back, and with history of PCI to LAD 2 into DES, and with another risk factor of positive family history, presented to us with chest pain and shortness of breath. 2D echo showed severe LV systolic dysfunction, and LVEF was calculated as 30 to 35%. Gated SPECT MPI with pharmacological stress and post-GTN viability protocol was advised. On stress images, we see a moderate to large sized area of absent radiotracer uptake involving apex and adjoining parts of apical anterior and apical anteroseptal and infroseptal regions extending into small adjoining part of infraapical region. Additionally, we saw a severely reduced to near absent tracer uptake involving mid to basal, inferior, and adjoining part of basal infroseptal region. On rest images, the pattern was essentially the same. So it was labeled as the impression was moderate to large sized non-viable defect involving apex and adjoining apical anterior and anteroseptal region, and along with another predominantly non-viable defect involving mid to basal inferior wall and adjoining part of basal infroseptal region. This was the severity map where we saw it was compared with the normal database of the normal patients, and we saw SDs up till 11 or 12, which was essentially the non-viable region. Our next case was 58 years of age, diabetic and hypertensive gentleman with history of NSTEMI 3 years back. 2D echo showed severe LV systolic dysfunction with LVEF of 20%. Chronoangio showed LMS critical at distal course, LAD critical osteoproximal course, and LCX and RCA totally occluded. Gated SPECT MPI with post-GTN viability protocol was advised. Here on the rest or stress scan, we saw a moderate sized area of moderate to severely reduced radiotracer uptake involving the inferior wall, which was relatively persistent on rest images, sparing small part of mid-inferior wall. So we labeled it as subendocardial scar, as the lesion was persistent on both the studies. Additionally, there was mild ischemia involving the anterior wall, which normalized on the nitrate augmented rest images. Our next case was 59 years of age diabetic and hypertensive gentleman with chest pain. 2D echo showed severe LV systolic dysfunction with LVEF of 20%. Gated SPECT imaging for evaluation of viable myocardium was advised. We did a single phase scan to rule out or to diagnose the viable myocardium. We did this scan after administration of GTN, and on this scan, it's not working, cell weak. We saw a large sized area of absent radiotracer uptake involving the apex and adjoining part of apical anterior anteroseptal region extending into infraposterolateral region involving small part of basal infroseptal region. So we calculated the viable myocardial segments in this region as 1, 2, 3, 4, 5, and 6, 6 by 10 LAD, and 1 by 4 RCA, and 4 by 6 LCX. Time. I hope I'm not exceeding time. Time up? Okay. This was the severity map. So I think I'm exceeding time, and I thank you all for patient listening. And if there is any question, please. Thank you very much, and good luck for the upcoming sessions.